If you have lumbar spinal stenosis, you have probably seen videos promising that 3 stretches will fix it and help you avoid surgery. But here's the honest answer. No exercise can permanently reverse a narrowed spinal canal. Nothing you do on a mat removes a bone spur, thins a thickened ligament, or reverses arthritis, but that doesn't make exercise pointless. The right program may help you settle your symptoms, maintain mobility, protect your leg strength, and build the endurance you need to keep moving. I'm going to demonstrate 4 movements, each with a different job: relief, mobility, strength, and conditioning. For each one, I'll explain what it's trying to accomplish, the common mistakes to avoid, and the symptoms you should never push through. Pay particular attention to the 4th movement. Many patients can still do it comfortably even after walking has become difficult. I'm Dr. Omar Ramos, a fellowship-trained spine surgeon. These movements are intended for the common pattern called neurogenic claudication, which entails heaviness, numbness, aching, or weakness in the buttocks or legs that appears when you stand or walk and improves when you sit down or lean forward. That pattern can suggest lumbar stenosis, but remember, it doesn't prove it. Hip disease, peripheral neuropathy, circulation problems, and other spinal conditions can produce similar symptoms. Your history, examination, and imaging need to fit together. If your symptoms began suddenly, affect predominantly one leg, consistently worse than when you bend forward, or do not follow this pattern, you may have a completely different problem. So get an individualized evaluation before treating this as your exercise program. The repetition numbers I give you are conservative demonstration examples, not a personal prescription. A trained physical therapist could evaluate you and give you that personal recommendation. Let's begin with the first job of these exercises, symptom relief. The first movement is not really an exercise. I call it the seated flexion reset. So you're gonna sit towards the front of a stable chair with both feet supported and slightly apart. Place your hands on your thighs. Slowly slide your hands towards your knees or shins as you lean forward. And allow your lower back to round gently. Pause briefly and then return only to a comfortable upright position. Do not lean backwards and do not force yourself completely straight if that immediately reproduces your leg symptoms. This places the lower back in roughly the same position you find naturally when you lean over a shopping cart. Bending forward may temporarily create a little more room around the nerves and allow position-dependent symptoms to settle. Notice the word temporarily. This movement does not remove the bone spur or shrink the enlarged facet joints or permanently open the spinal canal. It is a position you can use to manage the symptoms. It is not a structural cure. A reasonable demonstration starting point is 5 slow repetitions. Some people also use this position briefly between walking intervals or during activities that require prolonged sitting. If leaning forward consistently increases your pain, sends symptoms farther down your leg, or produces dizziness, then stop, because this may not be the right movement for you. The second job of the exercises is mobility. This movement returns to that forward bend position, but now a supportive surface removes the balance demand. Lie on your back on a firm bed, treatment table, or exercise mat. Only use the floor if you can get down and back up safely. Begin with both knees bent and both feet resting on the surface. Bring one knee gently towards your chest. Hold behind the thigh or over the upper shin, whichever is more comfortable. Do not pull aggressively on your kneecap. Pause briefly, release, and then repeat on the other side. Your pelvis may roll slightly towards you, but the movement should still feel gentle. There is no price for forcing your knee as far as it will go. You may feel a comfortable stretch through your buttocks or lower back. Some people also find that their leg symptoms settle in this position. What you should not feel is increasing electrical pain, spreading numbness, or new weakness. A double knee to chest version creates more flexion, but more is not automatically better. That version may be difficult for people with hip disease, limited mobility, abdominal discomfort, osteoporosis, or a recent hip or spine procedure. Begin with one leg at a time, and then progress to 2 legs if you're comfortable. If you have recently had surgery or have specific hip or spine precautions, ask your own clinician before trying this movement. Those first 2 movements help manage symptoms and maintain comfortable motion. Neither one changes what your legs are actually capable of doing. That is where the next 2 movements become important. Here is what quietly happens with lumbar stenosis. Walking becomes uncomfortable, so you walk less. You walk less for long enough and your legs become weaker. Now, standing up, climbing stairs, maintaining your balance, and walking are all more difficult, and none of that additional weakness necessarily appears on your MRI. The third movement is the supported sit to stand. You begin in a firm, stable chair. A higher chair is easier than a low, soft couch. If balance is a concern, place the chair against a wall and have sturdy armrest or a stable countertop available for support. Do not use a rolling chair or anything that may slide underneath you. Place your feet roughly underneath your knees. Lean your trunk slightly forward. Think nose over toes. Push through your feet and stand. You can use armrests or countertops as much as you need. Then you want to sit back down slowly and under control. The lowering portion is where much of the strengthening work occurs. So do not simply drop back into the chair. Remember, you want to stand up, slowly come down. This exercise has nothing to do with permanently changing the size of your spinal canal. It is about preserving the leg strength that daily life requires. If standing fully upright provokes your symptoms, then stand as tall as you comfortably can without arching backwards or losing your balance. A conservative demonstration starting point is 5 controlled repetitions of standing and then slowly sitting down. And remember, quality is more important than the number. If knee or hip pain prevents you from performing the movement, or if standing produces severe leg symptoms, a physical therapist can select an alternative for you. That might be a seated knee extension or another supported leg strengthening exercise appropriate for your condition. Now, we come to the fourth job, conditioning. Patients tell me some version of this almost every week. I can barely walk for 5 minutes, but I can ride a bike for half an hour. That is not strange, and it's not in your head. Cycling lets you exercise in a position of relative forward bend. That position may allow you to train your heart, lungs, and legs without spending the entire session in the upright posture that provokes your symptoms. A recumbent bicycle provides more back support and is often easier if balance is a concern. An upright stationary bicycle is also reasonable if it is comfortable and safe for you. Adjust the seat so that your knee remains slightly bent at the bottom of the pedal stroke. If your pelvis rocks from side to side as you pedal, the seat may be too high. Begin with light resistance. Maintain a comfortable forward position without collapsing through your shoulders or craning your neck. For someone who has been medically cleared to exercise, 5 to 10 comfortable minutes may be a reasonable place to begin. Increase the duration gradually before you start adding meaningful resistance. And do not use the bicycle as a test of how much pain you can tolerate. Your symptoms should remain manageable and should settle after you stop. Stop exercising and seek medical attention if you develop any chest pressure, unusual shortness of breath, faintness, or lightheadedness. Those are not symptoms related to stenosis that you need to push through. If you do not have access to a stationary bicycle, consider supported interval walking. You walk for a manageable interval and stop before your symptoms become severe, not after. Recover by sitting down or leaning forward, and once your symptoms settle, then you begin another interval. Several shorter walking intervals may allow you to accumulate more total activity than one long walk that ends with increasingly severe symptoms. The goal is to build capacity gradually, is not to win a constant against your symptoms. The most common mistake is treating these as 4 versions of the same exercise. Remember, each movement has a different job. The seated flexion reset provides temporary relief from position-dependent symptoms. Then the single knee to chest provides gentle, supported mobility. The supported sit to stand protects the leg strength that walking and daily life require. Cycling or supported interval walking then builds endurance and cardiovascular capacity. A good program is not one magical stretch. It usually includes movements you tolerate, gradual strengthening, conditioning, education, and, when appropriate, individualized physical therapy. Now, we need to discuss the symptoms you should never push through. Muscular effort and familiar temporary symptoms are one thing, but progressive nerve problems are something else entirely. There are different levels of urgency, and they are not the same. You need to go to an emergency department immediately if you develop a new inability to urinate, unexpected loss of bladder or bowel control, new numbness around the groin or saddle region, or rapidly progressive weakness in both legs. Do not wait for a routine appointment if those symptoms appear. The next group is different, but still requires prompt assessment. Stop exercising and contact a healthcare professional if you develop new or increasing weakness in one leg or a new foot drop, numbness that is clearly worsening and does not settle, or severe pain that continues escalating after you stop. There is another pattern that belongs in a category of its own. If you develop new unsteadiness along with hand clumsiness, dropping objects, or difficulty with buttons in your shirt, that may indicate compression of the spinal cord in your neck or another neurologic condition, not simply lumbar stenosis. Stop exercising and arrange a prompt assessment. I'm working on a video explaining cervical myelopathy, and we'll have a link to it in the next few weeks. One final distinction. Leg pain with walking does not always come from the spine. If exertion reliably produces leg discomfort that improves simply by standing still without needing to sit down or bend forward, that raises concern for a circulation problem. No single symptoms leads to a diagnosis of what's underlying your problems. Your clinician may need to examine your pulses and evaluate the circulation in your legs. I have another video that explains that distinction in more detail. I'll put the link in the description. Also remember that exercise is not a test that you must fail before you're allowed to discuss any other treatment. The questions that matter are how much your symptoms are limiting your life, whether you are losing strength or nerve function, whether you can still do the activities that matter to you, and whether your symptoms, examination, and imaging all point to the same problem. Some people manage lumbar stenosis for years without surgery. Other people continue losing walking capacity despite doing everything reasonably asked of them. That is when a surgical conversation may become appropriate, not simply because an MRI report used the word severe stenosis and not because you failed to perform a particular stretch or exercise. These 4 movements will not reverse the arthritis or narrowing inside of your spine. Instead, think of them as a starting framework covering 4 useful goals. Settling position-dependent symptoms, maintaining comfortable motion, protecting the leg strength required for daily life, and building endurance. The best program is individualized. Measure success by how your function and walking capacity change over weeks and months, not by how you feel on one particular afternoon. If this was helpful, the rest of my lumbar stenosis series is linked below. Start with the video explaining why bending forward relieves stenosis symptoms. This explains the mechanism underneath everything you just saw. And to be clear, this video provides general education. It cannot determine which exercises are appropriate for your diagnosis, medical history, or current level of function. That requires an individualized evaluation. If you found this video helpful, please subscribe to support the channel. I'm Dr. Omar Ramos, a fellowship-trained spine surgeon. I'll see you on the next one.